السلام ورحمة الله تعالى وبركاته. Hello everybody. How is my voice? Is my voice clear?
Yes, it's clear.
Yes, it is.
Oh, okay, thank you.
Can it start in a couple of minutes? Yes, I can start the recording. I think someone is using the device.
Hello everybody. How is my voice clear?
Yes, it is.
Okay, thank you.
Can it start in a couple of minutes? Yes, I can start the recording. Someone is using the device.
Hello everybody. How is my voice clear?
Yes, it is.
Okay, thank you.
Sorry, I muted two of you. I think Fathiya and Muhammad. So I muted you. You can unmute it. Hello, everyone. Today we're going to start our meeting. So if the team is ready, we're going to go ahead. Thank you so much for attending.
Yes, good afternoon, Dr. Nader. This is Yassine Abdullah. Thank you so much for this opportunity. So we can start our first presentation that entails rehabilitation by Dr. Rasha Abdullah and Muhammad Abdullah.
Hello everyone. Thank you, Dr. Nadir. Thank you, everyone. We're gonna start the presentation. Me and Dr. Rasha, we are going to present the rehabilitation. And Dr. Rasha, she will start first.
I will log in from here. Thank you, everyone, for attending our presentation. Sorry, I used my daughter's account. My name is Rasha, but it's appear here for the things is running, I see. So thank you for the attending, and I hope you get the benefit of the presentation today. So We will start our presentation with rehabilitation in geriatric. You can hear my voice clear?
Yes, we can.
Okay. So go to the first slide. So our presentation is rehabilitation. Muhammad, you can go to the next slide. So the objective on today is to be able to describe systemic approach to assessment of the cause of disability, advantage and disadvantage of potential site of rehabilitative care, role of interprofessional team and care plans, how to adapt care to comorbidities and disability, basic requirement for rehab of common conditions. Next. Okay. Topic still, conceptual mode for geriatric rehab, site of rehabilitation care, team and roles, impact of comorbid conditions, element of comprehensive assessment, approach for diagnostic specific rehab, approach for commonly encountered rehab issues, mobility aid, orthodontics, adaptive methods, and environmental modifications. Okay, conceptual mode for the geriatric rehabilitation. Geriatric rehab assessment the status and needs of patients, matching treatment with a specific condition, and evaluating rehab outcome. The WHO, an International Classification of Functional Disability and Health, ICF, framework has two components, health condition and contextual factors. Okay, so disability and functioning are viewed as the outcome of interaction between health conditions, disease, disorder, injuries, and contextual factors, which include both environmental and personal. So site of rehab care. There is inpatient and outpatient site. Inpatient rehab hospitals, freestanding or attached to the acute hospital, skilled nursing facility. The outpatient is hospital-based clinic, independent clinic, day hospital settings, and home. So we have a table here. This rehab site of care, level of care requirement. There is a different level. So rehab site, level of care, and expected intensity of service and payment source. The first one is freestanding rehab hospital or rehab unit attached to acute hospital. This level of care requirement is 24-hour availability of the physician with training or expertise in rehab, 24-hour nursing care, intensive level of rehab service, interprofessional team to deliver coordinated program of care as evident by weekly team of conference, reasonable expectation of improvement. So the expected intensive of service and interprofessional team approach is required, and in most cases, this call for 3 hours of therapy, 5 days a week, of at least 2 therapists. This can include physical, occupational, or speech therapies in any combination. The payment source, Medicare Part A, day 1 to day 60, full coverage, day 61 to day 90, partial coverage but daily co-payment, more than 90 days, daily co-payment for up to 60 lifetime reserve day, more than lifetime reserve day, no coverage. More than that, no coverage. Okay. There is a Medicare skilled nursing facility or transitional care unit. This is the rehab site. The level of care is physician supervision within access of 24 hours day emergency basis, 24 hours nursing care, less intensive therapy needed, interprofessional team coordinate ideally with care maintenance of functional without progress can be goal of care. Expected intensity of services, daily therapy, 5 days a week, 1 hour a day or more as tolerated by patient. ADL, which is activity of daily level assistance and or skilled nursing care. The payment source also Medicare Part A, day 1 to day 20, full coverage from day 21 to day 80, partial coverage with co-insurance, and more than 80 days no coverage. The third level is home health. Level of care of requirement is face-to-face physician visit within 90 days to establish needs and orders, physician certified needs and plan of care every 60 days, skill needed required for homebound patient, including either intermittent, skilled nursing, physical, occupational, or speech therapy. Expected intensity of service, intermittent nursing or therapy provided in home can be no more than 7 days a week or 8 hours a day. Patient must have support system to meet needs of living at home. This covered by Medicare Part A. Last is clinic. The site of rehab is the clinic, hospital-based or independent. Level of care is the physician order skill need required rehab service to include physical, occupational, or speech therapy and review plan periodically. The expected intensive of services is intermittent physical, occupational, or speech therapy provided. Patient must be able to get therapy visit. The payment sources is Medicare Part B. There are annual cap on coverage, but this can be waived if medically necessary. Okay, choosing the site of care. Accumulating data shows correlation between the site of care and outcome. Example, outcome of patient with stroke or hip fracture is best after acute care, rehab. Physician should consider severity of impairment, need for ongoing medical management, functional status, ability to withstand active therapy, social support, need for full-time caregiver, insurance plan. Team and roles. Goal of interprofessional team: ensure patients receive efficient and effective care consistent of comprehensive assessment and intervention for the disabling illness and comorbid condition, the specific impairment and environmental factors that may affect activity and participation. The patient and family are care member of the team. Their expectation and preference must be considered. Also on team, nursing, physical therapy, occupational therapy, speech and language therapy, social work, psychotherapy, nutritional service, and prosthetic, orthodontic, and physician and nurse practitioner and physician assistant. Okay, role of the core health care provider of rehab. Okay, case manager. The provider is case manager, the provider, case manager, primary role or rehab team. Assist patient on family in coordinating service to meet recovery needs and transition towards discharge to home. The dietitian assists nutritional status recommended dietary change to maximize nutrition. Nurse, clinical nurse specialist, provide ongoing assessment of sign and symptom of illness, medical conditions, and educate patient and family, evaluate self-care skills. Nurse aid, assist patient with activity of daily living, assist patient with mobility, take vital signs measurement. The occupational therapist assist in activity daily of living and instrumental activity daily of living abilities, screen, visual perception, and cognitive. Provides home assessment, provides self-care skill training, make recommendations, and provide training in use of assistive technology, fabricate, splint, and treat upper extremity deficit. Orthodontic makes and fit brace and other devices to align and or support limbs. Pharmacists conduct through medication review, detect therapeutic incompatibilities, reduce or eliminate unnecessary medication use. Physician certified rehab needs supervise patient treatment, treat medical comorbidities, educate patients and family. Physical therapists assist joint range of motions and muscle strength, assist gait and mobility, provide appropriate assistive devices, instruct in exercise training to increase range of motion, strength, endurance, balance, coordination, and gait, treat with physical modalities, heat, cold, ultrasound, message, electrical stimulation, assist environmental barrier in planning discharge environment. Physician assistant or nurse practitioner contribute to post-admission assessment, supervise patient treatment, treat medical comorbidities, educate patient and family. The prosthetist makes and fit prosthetic limbs. The psychologist provide clinical and counseling patient and family. Social worker evaluate family and home care factors, assist psychosocial factors, provide counseling. A speech therapist assist all aspects of communication, assist swallowing disorder, treat communication deficit, recommend change in diet and positioning to treat the dysphagia. So impact of comorbid conditions. Comorbidity may interrupt or delay treatment and often require adaptive in the care plan. Many of the illnesses that can interfere with the rehab of the older adults are predictable and potentially preventable. Asymptomatic approach to assessment, prevention, a systematic approach to assessment and prevention and management of comorbid condition improves the chance of maximum benefit from rehab. So, reduce mobility, high risk of skin breakdown require in pressure ulcers. This is the specific comorbid like conditions. Clinicians should monitor pressure and weight bearing areas and modify footwear, wheelchair, and bedding as needed. Thromboembolic events, prophylaxis against should be a part of the routine care. Incontinence, structural approach to assess and treat of the bladder problem should be incorporated into the rehab service. Indwelling catheter increase risk of infection and rarely approach for the non-acute setting. Pneumonia risk is increased by inactivity, disorder, swallowing, and underlying lung disease. Clinicians should be aware of the risk of aspiration and modified diet as needed. Anemia associated with adverse outcome, including functional impairment, decreased muscle strength, and poor quality of life. Cognitive function, mental functioning is critical for rehab, which requires the ability to follow command and learn. Clinicians should be alert for delirium and screen for mental status and easily reversible causes. Also, depression, endemic in newly disabled individuals, can manifest as low motivation. Clinicians should screen for depression and intervene early with treatment. Seizure can develop after stroke, specificity can develop during stroke recovery. Intervention include physical therapy, muscle relaxant, or botulinum toxin can offer modest benefit. However, these benefits have not translated into improved function. Okay, diabetes and rehab. Diabetic patients are likely to experience change in glucose level and medication requirement. Actively level is a powerful factor in glucose metabolism. Increased caloric intake during recovery may also affect metabolic needs. Therapy personnel should know how to assist diabetic control, use a glycometer, and intervene for hypoglycemia. So cardiovascular disease and rehab. Patients with poor cardiac output may have extreme exercise limitation. Abnormal gait in a patient with coronary artery disease may worsen coronary symptoms. Patients with well vascular disease often have other peripheral vascular diseases often associated with insensitive or painful feet and high risk of skin breakdown. Comprehensive assessment primary components. Patient demographics, social support, home situation, example number of steps to enter a location or bathroom. Medical comorbidities, severity of current illness, prior functional status, medication reconciliation. Okay, so deficit in range of motion and flexibility. This is a comprehensive assessment assist impairment. Deficit in range of motion and flexibility, strength, sensory function, balance, cognitive, depression, swallowing and language, quality of life. So this is a stroke now. Talk about stroke epidemiology. People more than 55 years of age are at high risk of morbidity and mortality from stroke. Acute stroke occur in more than 800,000 people per year in the US. More than 80% are likely to survive, many with residual neurological difficulties. Stroke-related deficits are severe in about 1/3 of survivors. So goal of rehab, recovery for older adults with stroke is complex because of the variability of causes, symptoms, severity, and recovery. Regaining function, compensation for adaptive for functional losses, preventing secondary complication, assisting the patient in reintegrating into the community. So stroke, what to expect from the rehab? Patient is usually recovered to some degree. Recovery is most dramatic in first 30 days. Many continue more gradual for months, may continue for gradual for months. Number of deficit affect degree of recovery, time recovery. Many patients with mild or moderate stroke become independent in activity of daily living, but other aspect of health status may be affected. So stroke guidelines for rehab. Stroke severity should be assessed using the NIH stroke scales. Federal guideline for stroke rehab. Outcomes are best with coordinating interprofessional stroke specific. Therapy should start early, but later supplementary intervention may help. Okay, so neuropsychological approach. Constraint-induced movement therapy encourage patients to use the affected extremity. Treadmill, walking with partial body weight support. Speech and language therapy, cognitive retraining for attention or visual special deficit, compensatory training for short-term memory deficit. Medication for depression and emotional liability. So preventing recurrence. Assist patient for significant carotid stenosis and atrial fibrillation. Review indication for carotid endarterectomy and anticoagulation with warfarin, dabigatran, or rivapixab. Consider antiplatelet medication, AC inhibitors, or statin. Target hypertension and smoking. So now this is the hip fracture, the epidemiology of the hip fracture. Affected 300,000 people per year in US. 90% are as a result of fall. Mortality about 5% during initial hospital stay and about 25% in the year following fractures. 75% of patients recover to prior level of function, but up to 50% of those require an assistive devices. About 50% of patients require transient long-term care, and about 25% of those remain in long-term care 1 year later. So hip fracture rehab goals: pain management, mobilization, and prevention of complications such as delirium and thromboembolic effects. Key factors influence recovery are early mobilization and how frequently therapy is provided. Acute rehab after hospital discharge appears to result in superior outcome. So the hip fracture medical management includes intervention to relieve a pain and restore bone alignment to allow fracture healing and prepare the older adults to return to their prior level of function. Evidence that management by geriatricians and orthopedics surgeons can result in improvement outcomes. Reduce lengths of stay, low complication rates, low mortality, reduced cost. Home management service need to be interprofessional with shared decision making, equal responsibility for the patient, and daily communication. So the hip fracture surgical repair, early repair, like within 24 to 72 hours after fracture, reduce 1 year mortality and complications such as pressure ulcer and delirium. Delay warranted for medically unstable patients. Surgical approach is determined by location of the fracture, pressure or present or absent of displacement, pre-fracture mobility. So hip fracture is a femoral neck, no disadjustment and intact blood supply, corrected with screw. Any degree of displacement and or poor circulation usually treated with prosthetic femoral head, hemoarthroplasty. Displacement and significant underlying bony acetabulum disease, complete hip arthroplasty may be warranted. Immediate weight bearing usually okay, regardless of surgical technique. So the hip fracture intertrochanteric, the treatment of choice is open reduction and internal fixation with compression screw or similar device. If joint is unstable, full weight bearing is often not allowed for up to 6 weeks. Mobility performance can be assessed with the Harris hip questionnaires and numerous other instruments. So prevention of recurrence from hip fracture, diagnosis and treat osteoporosis and balance problem. Hip protectors do not appear to reduce the incidence of hip fracture in community living older adults. So total hip and knee arthroplasty. In US, joint arthroplasty is most common elective surgical procedure, about 400,000 done annually. Primary indications are progressive pain and limitation of mobility despite conservative care. Plain radiographic are the usual method for determining the severity of joint damage at both the hip and knee. Long-term result with significant pain relief and improved function success rate of 90 at 10 to 15 years after joint replacement. Implant losing is most common reason for failure. So total hip arthroplasty type of surgery, the prosthetic and approach used for total hip arthroplasty are determined by the surgeon and based on the condition of the joint and integrity of the bone. Anterolateral approach, precaution, avoid external rotation, abduction, and extension of the operated leg for about 6 weeks. Posterolateral approach, precaution, do not internally rotate or abduct the leg and not flex the hip beyond 90 degrees for about 6 weeks. Many surgeons use a minimally invasive technique resulting in quicker recovery. Total knee arthroplasty, various types of prosthetic knees are also the type used depend on the joint damage. Typically, patients can begin bearing weight on the operated leg by the first day or 2 after surgery. Precaution, rotation or Torsion at the knee should be avoided for about 3 months. Surgeons are using minimal incision to achieve greater knee flexion, decrease blood loss, and length of stay. Total hip and knee arthroplasty immediate post-operative period. Anticoagulation with low molecular weight heparin or adjust dose warfarin. Pain control often with opioid. Early mobilization is the standard of care. For patients at high risk, more than 70 years or having more than 2 comorbidities, inpatient rehab improve function, decrease length of stay. Total hip arthroplasty, to decrease the risk of dislocation, patients should avoid motion such as bending over to tie shoes and crossing their legs. A raised toilet seat and top bench are recommended for the first few postoperative months. Rehabilitation focus on muscle strengthening, especially the adductors. The total knee arthroplasty recovery of range of motion is key to return of functions. Continue passive motion machine CPM, decreased need for amputation, combined with physical therapy. It is increased range of motion, decreased length of stay. To reduce the swelling, compression stocking, CPM, and cryotherapy. So now it is the lower extremity amputation epidemiology. It will continue with Dr. Muhammad.
Hello, thank you, Dr. Rasha.
Yeah.
Lower extremity amputation epidemiology. Necessary for 1,100,000 people each year in the United States, most with a systemic vascular disease. Those with diabetes often have other end organ disease. For example, blindness, end-stage renal disease, peripheral neuropathy. Mortality, about 50% at 2 years and 70% at 5 years. For up to 20% of patients, amputation of contralateral leg is needed within 2 years. Lower extremity amputation rehabilitation. Preoperative, strength and flexibility exercise, education about recovery process. Postoperative, early mobilization if possible, prevention of contractures, wound healing, edema control, shaping of stump, psychosocial support. Phantom limb pain occur in 60% to 80% of patients. Treatment remains difficult. Prosthetic profile of amputee facilitates systemic assessment. Key factors to assess are prior functional status, stability of comorbid condition, cognition, upper extremity use, condition of stump, and other lower extremity. Focusing on medical management of underlying disease process that lead to the amputation is important. An individualized cardiac rehabilitation. An individualized medically supervised exercise program combined with an interdisciplinary focus on psychosocial, nutritional, and heart disease risk factor reduction. That's shown to improve exercise capacity, physical function, and quality of life, and to reduce mortality. Barriers to utilization are low physician referral, lack of personal resources, making attendance difficult. Pulmonary rehabilitation, defined as a comprehensive intervention based on a thorough patient assessment, followed by patient-tailored therapies, which include but are not limited to exercise training, education, and behavioral change, designed to improve the physical and emotional condition of the people with the chronic respiratory disease, and to promote long-term adherence to health-enhancing behavior. Pulmonary rehabilitation continuum, traditionally provided to stable patients with moderate to severe chronic COPD. Recent studies have shown that rehabilitation in pre-exacerbation period can reduce hospital admission, effective with equivalent benefit in patients with non-COPD respiratory disease. Refer any patient with the functional status limitation or persistent respiratory symptoms despite otherwise optimal therapy. Shoulder rehabilitation. Shoulder disorder, more common in older men than older women, contribute to disability and impact quality of life. Because of the limitation, especially if the dominant extremity is involved, older adults will have difficulties with ADL activity of daily living, such as putting on a coat and combing their hair, as well as IADLs, which is instrumental activity of daily living involving in reaching overhead. Conservative shoulder rehabilitation. Conservative non-operative medical management is the preferred approach, with referral to outpatient occupational or or physical therapy to decrease pain and improve function. Okay. Functional use of involved extremity may be determined using standardized self-assessment, such as disability of the arm, shoulder, and hand. Outcome measure, which measures changes in the symptom and functions throughout the recovery process. Sorry. Therapeutic exercise aim to gradually increase passive range of motion of the shoulder and strengthen the elbow, wrist, and hand. Shoulder exercise should progress to active range of motion and isometric exercise as patient recovers. Rehabilitation services are discontinued when the patient has returned to completing daily activities, has been free active motion, and has maximized muscle strength. Mobility aid, orthotics, adaptive methods, and environmental modifications. Estimated 6.8 million of Americans are assistive technology devices to enhance mobility. Important to obtain a physical and occupational therapy evaluation early in the hospitalization to assess for equipment needs, including mobility aids and adaptive equipment. Early assessment is critical to providing older adults with the correct equipment to maximize their independent function. Important to identify underlying causes of disability before prescribing a device or modification. Medical or surgical treatment for individual disease and impairment may be more effective or may enhance useless of these approaches. Commonly prescribed mobility aids. So we have the assistive device and it is characteristic and prescribed condition. The first assistive device is a straight cane, which provide unilateral support, assist with balance and proprioception, and reduce weight bearing on opposite leg. Prescribe it for osteoarthritis of the knee or hip, peripheral neuropathy. And the other device is quad cane, which provide unilateral support, more stable than a straight cane, allows greater weight bearing on device. Prescribe it for patient with the stroke and hemiparesis. And also we have a stationary pickup walker, which provide bilateral support, must be lifted and advanced, and requiring strength and coordination. Very stable and allows non-weight bearing movement. And prescribe it for hip fracture, in which non-weight bearing needed, and unilateral amputation before prosthesis. Also, we have a two-wheel walker, which less stable than a stationary walker, but easier to advance. Allows for smoother and faster gait. And prescribed for deconditioning, Parkinson's disease, and for a patient with the total joint replacement. Also, we have a rollator, four-wheeled walker with the seat and brakes, which is less stable but allows for smoother and faster gait. Require more coordination and safety awareness because of brakes. Good for outside walking because of large wheel, and has a seat for resting. And prescribed for cardiopulmonary disease and peripheral neuropathy with the balance difficulties. Also, we have the manual wheelchair, which requires use of arm and some cardiopulmonary endurance, often used in nursing homes and by the caregivers for easy of patient mobility and easy to transport, and prescribed for non-ambulatory patient with cognitive impairment and low-level spinal cord injury. And we have a power wheelchair, which allow community mobility for those with limited ambulatory ability. And control don't require intact upper extremities. Need cognitive ability to operate safely, and may need home modifications. And prescribed for patients with a neurologic disease, for example, high-level spinal cord injury, multiple sclerosis, and amyotrophic lateral sclerosis, and also for the patient with a multiple limb amputation. And also we have the scooter, which is a similar has a similar benefit to the power wheelchair, except need to operate with the upper extremities, and may be more acceptable to the patient than power wheelchair, and prescribe it for the patient with cardiopulmonary disease. Mobility aids cane. The cane support 15 to 20% of the body weight used in hand contralateral to affected limb. Degree of support increases with increased number of tips, but cane becomes heavier and more awkward to use. Proper length is important for stability. To determine length, measure the distance first from the distal wrist crest to the ground as the patient stand erect. And also we measure from the greater trochanter to the ground. And we have the straight or quad cane, straight or quad cane. They provide unilateral support, assist with balance, reduce weight bearing on opposite leg, and small and large based quad canes are available. We have the crutches. We have two crutches, auxiliary and forearm. They use to provide bilateral support. The auxiliary crutches are seldom recommended for older adults because greater arm strength and coordination are required for use. The risk of brachial plexus injury if used incorrectly. They have a risk of brachial plexus injury if used incorrectly. The forearm crutches are more functional because a cuff secures the crutches on the arm, allowing use of the head and allowing use of the head. And also we have the walker. The walker can completely support one lower extremity, but not full body weight, and should be adjusted so that the user maintain an erect posture and does not lean forward to reach the walker. Pickup, we have the pickup walker, which requires strength and cognitive ability to learn necessary coordination. And also we have a wheeled walker. A wheeled walker allows smoother, more coordinated and faster gait, and more likely to be used correctly by people with cognitive impairment. And we have a stationary pickup walker. This is a picture, which provide bilateral support and must be lifted and advanced, requiring strength and coordination. Very stable and allows non-weight bearing movement. We have a rolling or rollator walker, which is less stable than stationary walker, but easier to advance. Allows for a smoother and faster gait. The rollator required more coordination because it has a brakes and safety awareness. The rollator good for the outside walking because of large wheels. And the wheelchairs. The wheelchairs required for a patient who cannot safely use or are unable to ambulate with other mobility aids. Must be fitted according to the patient body build, weight, disability, and prognosis. Incorrect fit can result in poor posture, joint deformity, reduced mobility, pressure ulcers, circulatory compromise, and discomfort. The Rehabilitation Engineering and Assistive Technology Society of North America Wheelchair Service Guideline provide detailed information to determine the most appropriate wheelchair for the patient. And also we have the scooters. The scooter required for a patient who cannot safely use or are unable to ambulate with other mobility aids. We have the motorized wheelchair may be used by mentally alert people with a bilateral arm weakness, other neurological disorder that limit arm use, or severe cardiopulmonary disease who lack endurance to push a wheelchair. And motorized scooter offer less strength support than motorized wheelchair, but are more acceptable to some people. Use increases mobility, but there is a risk of deconditioning because patient may otherwise push a wheelchair or ambulate. Orthotics. Orthotics are exoskeleton designed to assist, resist, align, or stimulate function. Name it by the use of the letters of each joint involved. For example, an AFO, which an ankle and foot orthotic device used to support weak pretibial muscles, may also benefit patients with the spasticity. Adaptation to facilitate dressing. So may be necessary for older adults with the problems such as range of motion loss, decreased strength, incoordination, and limited endurance. Adaptation include shirts that fit overhead or fasten in front and allow freedom of movement. Hooks and loops, velcro fasteners, put on hooks with customized grips, long loose socks, long-handled shoehorn, elastic shoelaces that need not be untied. Also, environmental modification. The environmental modification can have a major impact on the older adult's ability to function independently or with a minimal assistant at home. The environmental modification include assistive device such as riggers, doorknob extenders, special utensils, and adapted telephones. Grab bar installed near the toilet and in the tub or shower. Raised toilet seats and bathtub benches. Long-handled bath brushes, hand-held shower faucet, and soap on a rope. Okay, summary. For the summary, so the WHO model for the rehabilitation consider the interaction of body functions and structures, health condition, activities, and participation, and environmental and personal factors. For an inpatient rehabilitation hospital to be Medicare certified, a certain percentage of patients must have at least one of 13 conditions and receive a 3 hours of the therapy 5 days per week. The patient and family are core members of rehabilitation team. Many of the comorbidities that would otherwise interrupt or delay rehabilitation can be prevented or managed. Optimal rehabilitation outcome depend on comprehensive assessment of the patient, coordinated interprofessional management, multifaceted interventions, and access to appropriate and high quality care. Mobility aids, adaptive devices, orthotics, and environmental modification can be used to increase function and quality of life. Okay, now we have a question. Yes.
Thank you so much, both Dr. Mohammed, and we can skip the questions, the cases, but thank you so much, both of you. Great presentation. It's just for the sake of time. We're gonna skip the questions. If you have enough time at the end, we can come back to the questions.
Thank you.
Okay.
But thank you so much, Rasha. Thank you so much, Mohammed. This is great. It's a big topic, and in nursing homes, most of them they have section, and here from the hospital for the rehab, and they go through assessment, and then they make the plan for their rehabilitation. And the goal, as you mentioned, is to get them back with their strengths, and hopefully they can go back home and life's presentation.
Okay, thank you, Dr. Nadir, for the opportunity, and thank you everyone for the attendance. I'm going to stop sharing my page.
Okay, thank you, Dr. Mohammed and Dr. Rasha. So our next presentation is going to be about imposter phenomenon and self-confidence. That's going to be presented by Dr. Talal Abbas.
Hello, everyone. Nice to meet all of you. Today I will present imposter phenomena and self-confidence. Really, this is the first time I heard about that. It was so enjoyable to prepare this presentation. I watched a lot of videos to know what's the story. I hope also all of you enjoy that. Imposter phenomena introduction. Medicine is often characterized as a high-stakes profession with an evaluate culture, little room for error, and tendency to be populated by high achiever. From the outset, physicians are trained in cultures that expect excellence and the provision of separate patient care with a little room for failure. As a result, when error or expectation is not met, this can create inaccurate self-assessment streamed with anxiety, guilt, and self-doubt. Definition, self-confidence. Self-confidence is an attitude about your skills and ability. It means you accept and trust yourself and have sense of control in your life. You know your strengths and weakness well and have positive view of yourself. You set realistic expectation and goal, communicate assertively, and can handle criticism. Really, in this presentation, I will concentrate in the imposter syndrome because, you know, imposter syndrome itself, it affects your self-confidence. We'll start with also a definition of imposter syndrome. Imposter syndrome is a mental condition where a highly accomplished and successful person feels like a fraud because they paradoxically believe they are not as skilled, talented, or competent as the people perceive them to be. The sufferer experience persistent and intense internalized self-doubt and fear of being exposed as a phony. History of imposter syndrome. Imposter syndrome was first described in Georgia State University, a study by clinical psychologists Suzanne Ames and Pauline Rose in 1978. In their research, the psychologists explained self-declared imposter fear that eventually some significant person will discover that they are indeed intellectual imposter. You know, the story of this discover, you know, this the group of these psychologists, they have a friend. Usually all the time she has a high score and she has a good career. When they ask her how you get this score, or how you improve yourself in this career, all the time she said for them, I don't know. It could be a luck. From that point, they start to think about this imposter syndrome. And also, when I read about that, I remember our friend and colleague in the university. Some people, they have a high grade during the school time. When you ask them about the advice, or they said for you, I don't know. I think about that after this topic. It could be they have imposter syndrome, or could be a liar or something. Prevalence of imposter syndrome. Research suggests that around 70% of people are affected by a condition at least once at some point in their life. According to recent 2020 study, the prevalence rate for condition range from 9 to 82%. based on the cutoff and screening tool utilized the diagnosis syndromes. The study adds the prevalence rate were particularly high among ethnic minority groups, especially here in United States. They find it is common with the people of color. Imposter syndrome was common among both men and women. And some study also, they said it is more common in the women, working women. And across a range of age group, adolescents to late stage professionals. Type of imposter syndrome. The perfectionists set unrealistically high goal and are never satisfied with their achievement. The superhero, these people feel they must excel in all the different roles they play in their life. Just 1 minute, I want to. The expert, the 1 minute. I can't remove the videos here, the pictures. The natural genius, these people think intelligence must be inheritance. The psychologist, they left work alone because, I can't see the picture here. How can I do that? I don't know.
But we are seeing clearly. The screen share is very clear.
Okay, but for me, I saw the half of it. Anxiety, depression, and imposter syndrome. Unfortunately, the people of imposter syndrome always they didn't seek for help. This is a biggest problem, and when they suffer in that for a long time, this imposter syndrome can lead for depression, and sometimes for anxiety, and sometimes for low self-esteem, somatic symptoms, social dysfunction, and finally can lead to social ideation and attempt. Imposter symptom and sign, it can be having severe self-doubt, low self-esteem, and poor sense, overthinking, being an achiever, self-criticism and downplaying, self-spotting their own performance and success, and stress. The other screen, I didn't saw it. If you believe that you may be suffering from this condition, then you need to ask yourself this question. You can, anyone of you can answer this question, and he can keep this answer for himself within 2 minutes. Is that okay? Oh, and now I'm okay. I think the 2 minutes is finished now. If you have answered yes to most of this question, then it is likely that you are suffering from imposter syndrome. However, it is crucial to seek medical help or visit a therapist for an accurate and proper diagnosis. For me, I have a sort of that. Causes of imposter syndrome, over expectation from family. I think, especially when you have a good score during the school time, every time your family, they expected more and more to be the fairest in the class and like this, that it can be cause of imposter syndrome when you become old. Also, the childhood experience, if you, for example, you have your brother has intelligent more than you, and all the time he achieve everything's more better than you, also that it can be lead for that. A race and ethnicity, as I mentioned before, they found the black or the color, people of color here in United States has a high prevalence to develop this imposter syndrome. Sexual orientation, they found especially that is clear with the people of LGBT population. Field of work, academic field, and also like our field, also the medicine field, they have a high prevalence for that. Facing new challenges, when you have a promotion and in your work, sometimes you can develop this. Perfectionism, as mentioned before, the people when they want everything to be correct and to be in time, and they think about the perfection, they can lead to that syndrome. Personality triad, there is some type of personality, they have a high incidence to develop imposter syndrome. Complication associated with imposter feeling, apart from comorbid conditions like stress, anxiety, and depression, as I mentioned, that one of the biggest issue with the people suffering from the imposter phenomenon is that they often refrain from seeking help for their condition, although it may not be recognized as a medical diagnosis, because until now they didn't recognize that as a psychiatric disease. Imposter syndrome can have a serious negative effect in the sufferer personal and professional lives. Diagnosis of imposter syndrome, there is a special tested or scale. One of them, Harvey Imposter Phenomenon Scales, HIBS, and Clance Imposter Phenomenon Scale, CIBS, and Perceived Fraudulence Scale, BFS. Treatment of imposter syndrome. The treatment of imposter syndrome mainly depends in behavioral therapy and cognitive therapy. And the people they suffer can get a benefit from group therapy. And also there is a Gestalt therapy. This is a special kind of behavioral therapy. Lead the person to be responsible about his feeling all the time. Coping with imposter feeling. Firstly, you have focus in the fact, seek help, seek internal validation, shift your mindset, visualize success, identify imposterism, focus in the positive, practice self-compassion, fake it still you make it, failure lead to growth, don't compare with others, talk openly about your emotion. Overcome imposter feeling. Most of the time, people suffering from imposter syndrome fail to realize that they can stop feeling like this and improve their lives. They don't have any idea it is possible not to feel so anxious and fearful all the time. Says psychologist Susanna Imes, however, since you learn to recognize your imposter feeling and become aware of it, you can take the necessary steps to overcome it. The reason we like an imposter is that we have an experienced success, and lasting success can never be achieved without talented and hard work. So instead of attributing your success to luck or other factor, take credit for achievement and can be grateful. Consult a mental health professional to free yourself of your imposter feeling and tap in your inner self. Imposter syndrome at a glance. Imposter syndrome is a psychological phenomenon involving intense feeling of self-doubt. It can affect a person's professional and personal life and make them skeptical of their success. People with this condition often experience worry, insecurity, and anxiety, and depression as a consequence of imposter feeling. Although imposterism may lead to severe self-doubt, it may motivate some sufferer to work harder and achieve more in their career and life. One of the biggest issues with people suffering from imposter phenomena is that they often refrain from seeking help for their condition. Thank you.
Thank you so much, Dr. Talal, for this also.
Thank you, Dr.
important
Nadir.
topic, and I think you covered it very well. Thanks. So, as he mentioned, so to summarize, every one of us wants to be successful. And at one point, you might think negatively about yourself. So just focus on the positive side. We don't want you to be arrogant, but at the same time, we don't want you to lose your confidence. We want you to build your self-confidence. And that's an important topic. And maybe we can talk about that in the next coming sessions or so. But that's an important topic. Thank you so much.
Thank you, Dr. Nadir, and thank you for all the group for this opportunity. Thank you.
Thank you, Dr. Talal. We have somebody who has a question. Dr. Malaz, go ahead. Dr. Malaz, do you have a question? Because I see that you're raising your hand. Okay, I'm assuming it was by mistake, probably. If there are no other questions, we can go ahead with the third presentation.
Yes, go ahead.
Okay, so the third presentation is going to be about chi-square test. The presenters are Dr. Maya, Dr. Muhammad Al-Mujtaba, and Dr. Ihab.
Yes. Hello, Dr. Nadir. Hello, everyone. And the topic, now I'm going to present chi-square test. So let me share my screen.
Dr.
Talal, please.
You can
can
just.
you please stop the screen here? So.
Dr. Talal, you have to stop sharing your screen so that Dr. Maya could share hers. Thank you.
Thank you. Everyone able to see my screen share?
Yes.
Thank you. First, I want to give the introduction about the chi-square test and characteristic of the test, and chi-square distribution, application of chi-square test, and condition for the application of chi-square test and limitation. So then first, like the chi-square test is an important test amongst the several tests of significance developed by statisticians. It also developed by it was developed by Carl Pearson in 1900. Chi-square test is a non-parametric test, not based on any assumptions or distribution of any variable. This statistical test follows a specific distribution known as chi-square distribution. So it's not dependent upon any parameter. So in general, the test we use to measure the differences between what is observed and what is expected according to an assumed hypothesis is called the chi-square test. Okay, then important characteristic of chi-square test. This test is a non-parametric test based on frequencies and not on the parameters like mean and standard deviation. The test is used for testing the hypothesis and is not useful for estimation. This test can also be applied to a complex contingency table in research work. This test is an important non-parametric test as no rigid assumptions are necessary in regard to type of population, no need of parametric value, and relatively less mathematical details are involved in this. Okay. Then we have chi-square distribution. This is simply like if x1, x2, and up to the xn, means at infinity, are independent variables, and each is distributed normally with mean of 0 and standard deviation unity, then x1 square plus x2 square plus till xn equals sigma xi square is distributed as a chi-square test like c square. With the degree, with n is the number and degree of freedom is present as a d dot f. Where n is large, the chi-square curve for degree of freedom equal n equal 1, 5, and 9 as follows. So this is okay. How may I? This one. Okay, no. Let me. I'm not able to maximize this graph, but like on the graph, on the x-axis is like giving the chi-square distribution, and on the y-axis is the probability. So as I already defined, if n is we are obtaining like degree of differentiation 1 and degree of differentiation 5 and degree of differentiation 9, so the curve will be changed according to how much like we are getting as the probability. So let me explain. If the degree of freedom is greater than 2, that means we are getting the distribution in a bell-shaped curve. If the degree of distribution is equal to 2, the distribution is L-shaped with maximum ordinate at 0. And if degree of freedom is less than 2, but greater than 0, the distribution is L-shaped with infinite or ordinate at the origin. Okay. Then we have application of chi-square test. This test can be used in goodness of fit of distribution, in the test of independence of attributes, and the test of homogeneity. So we have to see here. First, this test is enable us to see how does the assumed theoretical distribution such as binomial distribution, Poisson distribution, or normal distribution fit to the observed data. So here's a little bit like a small example. The chi-square test formula for goodness of fit is x square equals sigma O minus E square and times E, where O is observed frequency and E is expected frequency. Then the second, we have test of independence of attributes. And the test enable us to explain whether or not two attributes are associated. For instance, we may be interested in knowing whether a new medicine is effective in controlling fever or not. So X-square test is useful. In such situations, we proceed with the null hypothesis that two attributes, for example, new medicine and control of fever, are independent, which means that new medicine is not effective in controlling fever. And we have equation here: x square calculated if greater than x square tabulated at a certain level of significance for given degree of freedom, the null hypothesis is rejected. For example, two variables are dependent. How they are dependent? The new medicine is effective in controlling the fever, so they are dependent. And if x square calculated is less than x square tabulated, the null hypothesis is accepted. Here, two variables are independent. The new medicine is not effective in controlling the fever. So when the null hypothesis is rejected, it can be concluded that there is a significant association between two attributes. Then third, we have test of homogeneity. This test can also be used to test whether the occurrence of events follow uniformity or not. For example, admission of patient in a government hospital in all days of week is uniform or not can be tested with the help of chi-square test. So how here, like x square calculated if less than x square tabulated, then null hypothesis is accepted. And it can conclude that there is a uniformity in the occurrence of events, uniformity in the admission of patients throughout the week. Thank you. This is from my side. And now my other fellows, Dr. Al-Mustaba and Dr. Iha will explain the chi-square in more detail. Thank you.
Hello, everyone.
Okay, whenever you're ready, Dr. Mustaba or Dr. Ihab.
Okay, I think, hi, hello, everyone. I think the Rehab should be next, but if not, I'm ready to proceed.
For the sake of time, you can probably start.
Okay, no problem.
للتوسع في تقديم الخدمات الأساسية للمحتاجين وزيادة مظلة التأمين الصحي في الفترة المقبلة. هذه الدورة بإذن الله.
Okay, can everybody see the screen clearly?
Yes.
Yes, yes.
Okay, no problem. Then, hi everyone, my name is Mohammed from Green Team. I'll be talking to you today about how to calculate the chi-square. Probably is a topic that freaks everyone whenever it's brought, and I know everyone has struggled with biostats during their preparation for USMLE exams and probably in all the practical aspects of research. But this we're gonna keep it really simple. Um, we'll speak about the meaning of hypothesis. My colleague just explained to you that we use this test to actually see the association and to test the hypothesis. Is it valid or not? Um, so for us to understand this, I'm gonna go really quick on this, but because we have to have a fundamental understanding of this prior to me proceeding, because it's gonna be puzzling if this is not understood. So the hypothesis of research donates that first of all we use chi-square as she mentioned, for to test the association between any given categorical variables. And this association has to be between two variables, two or more variables. For example, if we're talking about that should be non-numerical. I mean, something that you cannot be given a number on. For example, level of education and gender. Let's say gender has two possibilities, is the male, female. For example, education level has lots of possibilities, but all of these are non-numerical. You can say high school, university, secondary school, and so forth. So everyone is clear on this. Okay, so we use it for to test the association between two categorical data. Okay, or variables. So then we have the null hypothesis. The null hypothesis donates that there is no difference between let's say there is no significant association between these two variables. For example, when we want to test if to test, for example, the level of or the frequency of illiteracy in genders, in both genders. So we can, our null hypothesis will be that there is no strong association, or there is no association between gender and the state of being illiterate. That's, everyone is clear on this. So this, we call it the null hypothesis. So we either at the end of our research, you either accept the null hypothesis or reject the null hypothesis. Of course, we do research aiming to probably most of the times we want to reject that null hypothesis, and because our initial purpose of research would be to find a difference in this, but the null hypothesis will always state that there is no difference, there's no statistically significant difference between the two variables. Okay, so just to go quick here on the types of error, this table makes it very simple for everyone. So we have the null hypothesis being whatever you want to test, and then this is the outcome and the reality after you do your all the testing and all the research here. So there is either a relationship or there is no relationship. So if there is no relationship between the two variables and you end up accepting the null hypothesis, which states that there is truly no association between the two variables, then your decision is correct. If you, on the other hand, there is actually no relationship between the two variables, but you rejected the null hypothesis. And what does it mean when you reject it? It means that you think there is an association between the two variables and you've committed what we call an alpha or type 1 error. Then if in reality there is relationship or there is an observed relationship, and but you accepted the null hypothesis stating that there is no relationship, then you've committed what we call a type 2 or beta error. And then here we have if the relationship between the two variables exists truly, and you rejected the null hypothesis, indicating that your results are showing that there is an association, while in fact there is an association, then you've ended up in a correct decision. And this we use it to actually determine the bar of the study. So actually what we call the B value stems from this, and it's the ability to safely reject or accept the null hypothesis, meaning that you have very little slim chance of committing a type 2 error. Okay, so so generally the cutoff point is determined by complex calculations in all of the softwares like SPSS or other softwares, but generally we accept risk of less than 5% that our conclusion is due to mere chance or random chance. Okay, so this is the cutoff value. When you take your the end I'll just tell you in a minute how to calculate the chi-square, but then you're going to compare this chi-square to the 5% risk, the number you have to this number, and if it's I think greater than this or lower than this, it will have a different meanings on both possibilities. So to start with, we can have this simple. So it tests, as we said, the homogeneity and the goodness fit and the independence of the attributes or the variables. And here we go. So how do we calculate this? For example, this table will show you the idea. So again, I've said that the chi-square should be measuring the association between two categorical data, but as you see here, we have numbers. So where do these numbers come from? Let me take a very simple example. So the first variable here being gender, either men or women, and here the other categorical variant is like if people would choose between money, love, and health, for example. Okay, so both of these are categorical. If you choose one of these, this is definitely categorical, and this is also categorical. But the numbers come as the frequency of this observation. For example, when we asked men, 82 of them, that means the frequency of choosing money was 82. The frequency of choosing health was 446, and so forth. So this is where the numbers come from. So don't get it confused. Okay, if we're mentioning the number of frequencies between two categorical variables like this here: money, health, love, men and women. Okay, so these are the observed frequencies. These we call them the rows, and these are the columns. So to calculate, it's very easy. This is the, but again, nobody does it today. Nobody does it on the manual way. We just go to the applications or softwares, and it does everything. You just have to enter it. Anyway, this is the chi-square, and it equals the summation of the observed values. Going back here, for example, here we have the observed values or the frequencies of men choosing money is 82. Okay, so the observed value is 82. Then we have to calculate what we call the expected value. We have to find the difference between this, find the square root of it, and divide it by the expected frequency of men choosing money. As simple as this. And then we sum up all the other variables as we did with money here, and we go on. So as you can see, so we use the total number of frequencies in a column and in a row to calculate the expected frequency, and then we subtract the observed the expected from the observed frequency, and then we end up squaring them and dividing them by the expected frequency. So we can see here the measured frequency was 82, the expected frequency is 63, and so forth. So we do the calculation, we sum up all of these, okay, and then eventually here we have the calculated chi-square. Here is 36, for example, for this. And so for as I said, the Excel sheet will do the complex calculation of finding the chi-square corresponding to the acceptable level of 5%, which is 0.05, and this is the cutoff B value that we use to state that this is significant or not significant. So here it's calculated as 5.99. As you can see here, this is the table I told you about, and it's totally done by the software using the degree of freedom. So eventually we arrived at the calculation that the calculated chi-square is much greater than the critical chi-square, which is the chi-square corresponding to a chance of 5% of this observation being due to random chance only. And eventually then we can safely reject the null hypothesis that there is no association. So there is a true association, and is much implicated by a chi-square that is much greater than a chi-square accounted for random chance only, which is 5.9 compared to 33, for example, or 36, which is much larger. And we can safely reject the null hypothesis going back to our 4 2x2 table, and then we could have arrived at a true association between the two variables, meaning that the null hypothesis was not correct, and it could be rejected safely. So this is all about the calculation. As I said, nobody does it manually these days. It's just you have to have a fundamental understanding of this. But again, you have the softwares like SPSS and all the other available softwares online you can use to calculate your chi-square. I hope everybody found this useful. Any questions, just post them on the messages section. Thank you.
Thank you, Dr. Mohammed Al-Mujtaba, for your presentation. It's very informative and concise. I will talk about the use of, let me share my screen first. Yeah, I'm going to use how to use Google Sheets on to apply chi-square in the Google Sheet. So we do it's very easy, 3 steps mainly, and then we again is the null hypothesis. So we create our data, and then we do our statistic test, and then we calculate the p-value, and then we compare the p-value to the level of significance that we choose, either 5% or 1% or whatever. And so just in summary, so I have some example here. That's a small example, straightforward. Let's suppose that a shop owner claimed that he sees equal number of customers every day, and an observer came and counted the customer every day, like so Monday, Tuesday, number of customers. So first of all, we create our data in the Excel or in the Google Sheets, as we see the days and the observed. And then for this example, the expected is the shop owner expected that he sees every 50 customer every day. This is why we put the expected as 50 here. But you can calculate the expected value by like so. Here in the Excel sheet, you have your observation table, and then you copy it again and put expected here, and then to calculate the expected, you can do, this is another example, you can do it's the total row multiplied by the total column over the total of the table. So what you do, you type equal first, and then you type the total for the row, and then multiply, which you can find it by clicking Shift and number 8, and then you add the total of the column and divide it by the total of the table. It will give you the expected, and then you drag the whole thing like this, and it will fill all the other cells with the expected values. And then you calculate the statistic. You use the chi-square formula to calculate the test statistics values, and you can do it as Dr. Mohammed Mustafa said, it's the summation of observed minus expected to the power 2 over expected. So you do it like this. You do equal first. That means you are doing an equation, and then you open a brackets as you see here, and then you click on the observed, and then minus, and then click on the expected, close the bracket, and then you do this small sign, which you will find it by doing Shift and number 6, and then number 2. That means it's to the power 2, and then over the expected, and then you drag to the whole table, and it will fill all the cells. If it is a 3 by 3 table, it will look like this. It is the same concept: expected minus observed minus expected to the power 2 over expected, and then you drag the whole for the whole table like this, and it will fill all the cells. And then after that we calculate the p-value, and if you click on any cell in Excel sheet, and then you type chi, it will give you different options of chi. We first, to calculate the p-value, we use the chi-square distribution, in which you need the test result and the degree of freedom. And you do, like, you open a bracket, and then you do the test result, comma, and the degree of freedom, and close the bracket, and you press enter. It will give you the result, the chi-square distribution, or the p-value that you need here. And the degree of freedom, it's easily done by the number of rows minus 1 multiplied by the number of columns minus 1. For example, here in this 2 by 2 table, we find that the number of rows is 1, 2, 3, 4, 5. Minus 1 is 4, and the number of columns is 2. So minus 1 is 1. So it's 1 by 4 is 4. So the degree of freedom is 4 for this example, for example. But if we have like a 3 by 3 column table like this, the degree of freedom will be 4 because it's 2 by 2. And the same thing, we choose chi distribution. This is chi dist, and then we put the degree of freedom and the test result, and then we click enter, and we give you the p-value. And then the smaller the p-values, we test the p-value against the null hypothesis we had with specific significant level. If we choose like 5% or 1% or 0.1%, it depends on your degree of freedom that you want to choose. The smaller the p-value, the stronger the evidence that you have. You should reject the null hypothesis. The p-value less than 0.5% or 0.05 is significant, is statistically significant. It indicates strong evidence against the null hypothesis. There is less than 5% probability the null hypothesis is correct. And then finally, you check your work. Is the test statistic values is true, or the p-value is true? So you can first start with check the p-value by just clicking on a cell, any cell, and type chi, and then it give you a down drop-down menu. You choose Chi test, and then you need a range of observed. This is the range of observed. You click on the whole table, and it will automatically come here as this figure from B2 to D4, and then you do put comma, and then you click on the expected table, and it will be from B8 to this. In this example, from B8 to D10, and then you click enter, and it gives you the p-value, and then you compare the p-value you got here on the p-value you calculated before. If it is the same, that means all your work is excellent and good. And then you check also the statistical result. The same thing, you in any cell you type chi, CHI, and then you choose chi inverse, INV. And in this, you need the p-value and the degree of freedom. You have the p-value here, and the degree of freedom in this example is 4. And you put them here, and you click enter, and it gives you the test statistic. It must be as the same as the test statistic you got before. This is in a very simple way how to use Google Sheet in applying chi-square. It's easy, and I recommend everyone, if you want to know more about it, to look at the video that Dr. Nader has posted before. It's very simple, straightforward, and thank you for everyone. How to stop share. Hello.
All right, thank you, Dr. Ihab. And I don't know if anyone has any questions for Dr. Ihab. Okay, I guess there are no questions.
Thank you so much, Dr. Rehab, and the rest of the group. This is great presentation. Thank you.
You're welcome.
Maya and Muhammad. Okay, we can go to the next topic.
Okay, so our next topic is going to be about preparing for ERAS, how to improve your application tips and tricks. It will be presented by Dr. Hassan and Dr. Muhannad Al-Hassan. Whenever you're ready, Dr. Hassan and Dr. Mohammed.
Is Dr. Muhammad and Dr. Hassan on with us now? Any one of them?
I can't find any of them over here.
We can skip this and we can go to the next topic then.
This will be the conclusion. The other things that we have is any recap about any new ideas and projects.
So we have Dr. Malaz and I think Dr. Samah. If you have any update about the AAIC, we have 3 posters presented in the past few days at the conference, the Alzheimer meeting and international meeting. Do you have a minute to talk about that? Either Malaz or both Samah, or I don't see Lina. Go ahead.
How are you? How you are fine?
Very good, thanks.
Thank you. Yes, fortunately, we presented 3 of our posters in Alzheimer Association International Conference 2022. One of them, vitamin D influence on aging brain function. All were virtual. Vitamin D presented by me, and effect of music on aging brain presented by Lina, and dementia screening presented by Samah. I sent for you, I guess all we sent for you is a poster, and we can post it in our application, so all the fellows can take a look for the presentation and poster. I have new idea also. I want to talk about it.
Sure.
Actually, we started to have a new project, which is role of gut microbiota in diabetes mellitus. So me and 5 or 6 from the fellows, Abir, Lina, Lina Lata, Lina, and who's else? 5 or 6. We started to collect the data. We created a sheet, and inshallah we will start writing in the next few days. So if anyone is interested and want to join, welcome. And we will take your opinion when we will start writing, inshallah.
Inshallah. Excellent. Thank you so much for sharing. And this is great. So both the new idea and the presentations themselves. Thank you so much. This is excellent. Awesome.
You're welcome. Thank you.
Thanks for sharing.
Yes, I wanted to add, Alhamdulillah, Dr. Nader, as they said,
yes.
Yeah, we did the poster presentation, and we are thankful for Dr. Lubaba. She was working, but she's the one who guided us during that.
Yes.
We're waiting for them and their questions.
Yes, and also Sarah, she was very helpful, and Lina also. She did her poster and she helped me and Samah in presenting our poster also. And I have one message. I have one message from Lubaba. Just before the meeting, she messaged me and she's sending her greets for all of you.
Excellent. Okay. Yeah, usually it's a teamwork. So thank you so much, all of you, and the previous fellows, batch 1 or batch 2. This is really good stuff. Good job. Thank you. Anybody else wants to share new ideas or their projects, what you are doing, updating us. Any questions?
Assalamu alaikum, Dr. Nader. How are you?
Alaikum assalam wa rahmat. Very good. Thanks. How are you?
Alhamdulillah, it's Rian Hassan. So I'm doing the research project, the effects of anesthesiology on post cognitive impairment on the geriatric population. So alhamdulillah, we finished our data collection. We're actually right now starting the rating. The results section should be done by next week. And then hopefully in the next 1 to 2 weeks, we should be completed. So that's the plan moving forward. So alhamdulillah, we've come a long way. It was, yeah, I was fortunate to have a great group. So that's it for that.
Perfect. Excellent. That's good. Thank you for sharing. And let me know if you have other questions or need help. Perfect. Thanks for sharing. Anyone else?
Hi, Dr. Nader. This is Akila.
Hello.
Hope you're doing
Yes,
good.
go ahead. Excellent.
Well, regarding the project on varicella and myocarditis, we are working on, like, the discussion part is yet to be done. And once that is done, I think we can conclude with the conclusion. Probably by the end of next week, I can forward you the final draft for, for the addition and all that. Apart from that, regarding the webinar that we were supposed to host, we have, I think I forwarded you the subdivisions of the topics. I hope that is okay. And we're working on that. Like, we've divided and we're working on each topic respectively. And by August 20th or so, I think in a couple, like in 2 weeks, we would come up with the final presentation and present it to you. And accordingly, we'll make the changes. And we're planning to host a webinar in the first week of September. So once the preparation of the slides and everything is done, and once you feel that it's good and all that, then we would go with the outreach. Like, then we'll go, we'll fix the date, and then we'll approach the our population that we're supposed to reach. So that's all for now. Thank you.
Sounds good. Sounds good. Thank you so much, Akila, for the update. Yes, and go ahead with the division and assigning task, and hopefully we can be ready. Thank you, and good luck with step 3. And everyone.
Thank you so much, Dr. Nader.
Thank you very much, Dr.
You're welcome. Thanks. Now some other fellows are preparing for step 3. So I wish you all the best, all of you. Go ahead. Sorry, I interrupted you. Anyone else wants to update us about their projects? Any progress? Go ahead, Dr. Nafisa. Go ahead.
So I have 2 case reports, one about atypical mycosis congoids. That is almost done. I will share it with you very soon, inshallah. And another one that about anxiety as an early presentation of Parkinson's disease. That's also I will start working on. And I have a research that a kind of case control study that I want to do it, and I already start gathering the data. I need to just analyze it, and that's regarding this the role of the sodium glucose transporter in affecting the hormone hemoglobin A1C level in order to increase the benefit from sodium glucose transporter in patients either they're being diabetic or just take it as for cardiovascular prevention. So I will send you an update on those 3 projects.
Excellent. Sounds good. Excellent. Anyone else? I know some of you were working on the app development, some ideas. So that's good also. So if you have any questions, if you have any new ideas or you want to join certain teams, let me know. We're still working on the document that contains the recent projects. I'm gonna share that with you guys in the chat. For those who did not add their names, or you can look at the projects there, see if there is any active project they need some help, you can join the team. If you have ideas, you can add your ideas there. So we can keep track of what's going on. And this also will help. I know in the coming days, most of you will go through IRAS application. So if you need the letter of recommendations, it will help me when I write about you. If you can tell me like what projects you are doing, what presentation, if you did presentation, something like that. It's the letter will be personalized according to your need and task and objectives that you already met during the fellowship. So just to keep track, if you can update the document, that would be great. Any other questions, any other comments from any of you guys?
Dr. Nader, I just had one question.
Go ahead,
I think it was
Dr. Ryan.
spoken about last week, but I just want to confirm. So I know the researches should be directed towards the geriatric population, but is it possible to focus on a different population? So I was thinking about doing something in the pediatrics. Can I please have that affiliated with the University of Michigan? Is that possible?
That's absolutely. We are not inclusive. Like we are not totally about geriatric. The idea is to get the skills of doing the research from A to Z, and then you can apply the same method to pediatric, to surgery, neurology, psych, any way you want to go, you can apply the same methods. So it will help you as long as we can help you with the process. Whatever interest you are having, then you can go ahead. No limitation. The only limitation when you think about it is just when you had an interview. Let's say you applied to internal medicine. So if you apply and you mention that in your application or the resume, geriatric in research related to geriatric, working on, let's say, pediatric neurology or something, then you might have the question of how come you are in geriatric research fellowship and you are doing pediatric. So just be ready to answer that question. And the way I would advise you to answer it is, this fellowship is, the goal is to learn the skills and then apply it to whatever. So I'm interested in doing, let's say, if the program is internal medicine, say I want to do internal medicine and pediatric to cover the whole thing. Some programs are combined like that. Or if you apply for family medicine, then you can tell I'm interested in general family medicine, but also in geriatric, in pediatrics. That's why I did the research in pediatrics. So it just will be all together making sense for the program. Otherwise, they will say, oh, you joined this just to get something on your CV, but your real interest in pediatric, and now you are applying to internal medicine is kind of all over the place. For them, it might not make sense, and you will not be an attractive applicant. But if you,
they'll think you're confused. Yeah. Oh, I appreciate that advice. Thank you so much, Dr. Nader.
You're welcome. You're welcome, Dr. Ryan. But great. Yeah, go ahead. Meher, I'm going to add you to the list for the document. Sorry, I will send you an invitation. And then who else? And Sushma.
Hi, Dr. Nader. I have sent you an email about the mobile app poster questions. So just take a look whenever you get a chance.
Is it a simple question? Can answer now? Or?
No, I actually have. It's about the phone call that we discussed last week. So it's about that.
Okay.
Yeah.
I will look at that and then I will send you the answer. Excellent.
Thank you, Dr. Nader.
Anything? You're welcome. Thank you so much. Anybody else? Dua. Go ahead, Dua. You have question?
Yeah, hi, hello, everyone.
Hello.
I had a question regarding one of the case and control study that we're working on. I presented it to you last week. We were done with the literature search, and currently we're in the process of collecting the sample size. But I just wanted to know what's a good amount of cases and controls. If it's possible to do a ratio of 1 to 2, 1 case and 2 controls and match them. But we found out that there will be around 20 cases. It's not much. This is regarding the phosphodiesterase inhibitor in treating Alzheimer patients. So I was just wondering, is that would be a good enough number, or should we collect more data?
So the more the better in general, the concept of the in research. So what I would do is I will look at similar topics or drugs or method used and see how they did it and what the number used commonly. So if it's similar, then you can go ahead with this number that you have. If it's larger number, then maybe you can seek some other additional.
The thing is, it's a new topic. It hasn't been done much on. If I remember, it was mainly in mice. It's not done as much in human, and it was clinical based study. So it wasn't much of information there. So I just thought I'll ask, is 20 patients enough regarding the cases, or should we just include other?
I think we can go ahead. Yeah, I think we can go ahead with this number.
Okay.
But usually what I do is I will look at what people did the same, just to make sure I'm on the same page, like what they did with similar situation, not necessarily exact, and then see how that turn around. This can be applied to anything. When I'm writing an abstract, I will look at abstracts in the same area previously accepted in, let's say, ACP or some conferences, and then I will tailor my abstract so that it will be in the same.
Yeah.
Acceptable. Yeah.
Thank you so much.
Excellent. Thank you so much. No worries. Good luck. So we have Shaza, we have Samah. Go ahead, Samah. Or Shaza.
Yes, I have a question, Dr. Nader, regarding the letter of recommendation, please. Last time you mentioned something, I'm not sure if I get it right or not. You said while we are requesting our letter of recommendation through IRAS, we have to send you an email about the abstract that already we did, so you can mention it in the letter of recommendation. Or I didn't get that right.
So,
sorry.
But yeah, you're right. So what I'm saying is I have a template where I have a general letter of recommendation for everyone. And that will include when you join the program and you were involved in different activities, different research projects, and most of you are doing this. So that letter will go ahead no matter what area or interest. Let's say in neurology, I can just say you are interested in neurology or internal medicine, something like that. But sometimes fellows in the past, some of them send me their actual contribution. Let's say they did presentation, 2 topics, they led a team, and they presented 2 posters. So I will look at this and I incorporate this in the letter. So instead of being a general letter that saying you are involved in different activities and projects, I can mention specifically you did 1 poster at AMDA in 2021, and then another poster in AGS in whatever. So it will be just personalized to you according to what project or poster or anything that you did. So if you send me this, it will help me. I can look it up, but it may take some time depending on when you need your letter. So if that makes sense for you.
Yeah, thank you so much, Dr. Nader. I really appreciate it.
You're welcome.
Really helpful.
Anytime.
Thank you.
Thank you. Good luck. Okay.
Assalamu alaikum, Dr. Nader.
Alaikum salam.
Yeah, I just wanted to update you about our research, about literature review on the association between Alzheimer's disease and the chronic stress. We are now in the phase of writing, and after we did it, we will send for you a copy, inshallah.
Excellent.
Thank you.
Thank you. Good luck. Perfect. Anyone else with any questions or any comments? So Meher, I added you to the list for the document if you want to have access. If no more questions, then for next week, can I just share the
Dr.
plan?
Nader?
Yes, go ahead.
Hello, this is Shaima.
Hello, Shaima.
I just want to ask if you will be attending the SAPA conference next week, so we can meet you and have the pleasure.
In person. Yeah. Oh, it's gonna be better. I'm debating is whether or not I'll be able to. I'm interested in coming, so we'll see. If not in person, will be virtually.
Inshallah.
Jazakallah khair. You're gonna attend, right?
Yeah, inshallah.
You plan, inshallah. So there is Dr. Fadl. I think he wanted to present brief introduction about this program. So maybe if you attend, and he mentioned that if you want to add any information about your experience or reflection about so far how we are doing, that would be great also.
Okay. Yeah, inshallah. Thank you.
Thank you so much for that. Excellent. So I will expect from you all who applying to send requests for the recommendation letters, so I can just update or upload these letters for your application. Excellent. Okay, let's see if I can get the next week agenda. If there is any suggestions, also please email me. So for next week, we'll have the yellow team. Amy and her fellows will present, and I added the agenda so far. So if anyone from that team is not able to, they can mention that to Amy, and then they can or remove their names from the list so that we can be ready for next week. And you can also look at the week after for the green team if they want to also see how they can contribute if they are available. And I'm sure some of you might have other obligations or let's say preparation for step 3 or other things. They might not be available traveling. So if you can let your team leader know so that at least some of you will have the opportunity to participate and present. The more the better. Sometimes I put a lot of names. So if the topic is big, like today, you can divide it into small section, similar to what they did today. So 2 fellows can present or 3 fellows can present. Each one can handle 1 task or part of the topic. I think that will be helpful for you guys. And as far as presentation skills, confidence, and also you can put that in your CV, your ERAS application. Thank you so much, everyone. And okay, go ahead. I think someone is raising hand. Go ahead.
Assalamu alaikum, Dr. Nader.
Alaikum assalam wa rahmah.
Just another question regarding the letters of recommendation. So would you prefer to be contacted like through the ERAS, or should we ask you earlier so you can have it ready, or and maybe we can upload that?
When you request it through ERAS, it will come as an email with a number. So I will just use that number. Upload that. Yes.
Okay. Okay. So perfect. Thank you. Thank you so much.
If for any reason, you're welcome. No problem. If for any reason you didn't see it within a day or two, shoot me an email with the number, so that I will just use that number. So
Inshallah.
Thank you.
Inshallah. Appreciate it. Shukran.
You're welcome. Yeah, shukran. Thank you. So I'd like to thank the team for today's presentation, and really appreciate every one of you who presented today. And thank you for all who are present, attended the meeting, and in advance, thank you for those who will look at the recording later. I wish you all the best, and then see you next week. Assalamu alaikum.
Thank you, Dr. Nader.
Assalamu alaikum. Thank you.
Thank you so much, Dr. Nader.
Thank you, Dr.
Thank you,
Nader.
Dr. Nader.
Thank you. Thank you.
Thanks a lot.
Thank you.
Dr. Nader.
Thanks. Have a good day or night.
Thank you, Dr. Nader. Have a great day.
Thank you so much, Shada. Yeah, fine. Have a good one.
Bye-bye.
Thank you,
Bye.
Dr.
Assalamu
Nader.
alaikum. Thank you, Tamir. Have a good day. Bye-bye.
You too. Bye-bye.
Thanks.